Hello, I'm Dr. Jeffrey Weber. I'm a medical oncologist at the Laura and Isaac Perlmutter Cancer Center here at NYU Langone Health in New York City. I'd like to report to you today on 3 important oral melanoma abstracts presented at the recent ASCO meeting in Chicago, which ended just several weeks ago. The first and clearly important abstract was actually presented at the plenary session, and this was the first report by Dr. Christian Blank of the primary endpoint of event-free survival in the NADINA study, which was a randomized phase 3 study of 420 patients with clinically detected and/or palpable stage 3 melanoma who were randomly allocated 1-to-1 to either get surgery followed by adjuvant therapy, or they would receive 2 cycles of fixed-dose ipilimumab-nivolumab, roughly at 1 of ipi and 3 mg per kilogram of nivolumab, again, depending on the weight of the individual. And they would receive that for 2 cycles, then go to surgery for a total lymph node dissection, and then get adjuvant therapy. If they had a significant level of necrosis of 90% or more, they would get no further adjuvant therapy. If they had less than 90%, but more than 50%, they would continue on immunotherapy. If it was less than 50% and they were BRAF mutated, they would be receiving adjuvant dabrafenib trametinib. Primary endpoint, event-free survival, defined as the time from randomization till either recurrence, progression, or death due to their melanoma or their treatment. A little different than what we saw as the definition of event-free survival in the previously described SWOG 1801 trial. For the primary endpoint of event-free survival, very impressive difference for the neoadjuvant arm compared to the surgery adjuvant only arm, with a 26% point absolute difference in event-free survival, 83% versus 57% at a projected 12 months of follow-up. Please keep in mind the median follow-up here is only about 9.9 months, so it's still early days, but the hazard ratio is a very healthy 0.32 with a p-value of 0.0001 for the difference. Very impressive event-free survival difference favoring neoadjuvant therapy. If you look at BRAF wild type versus BRAF mutated, for the BRAF mutated population, very impressive 31% difference, 21% difference if you're BRAF wild type, but still clearly statistically significantly difference with an excellent hazard ratio in the 0.3 range. And as has been seen in other trials of this type, a 90% pathologic response or more gave a very low rate at 1 year of recurrence of 4 to 5% at most, whereas it significantly dropped off if you had less than a 50% level of pathologic response with less than 50% necrosis, 57% event-free survival at a year, and 76% if you had between 50 and 90. So those are the patients who probably would benefit from further adjuvant therapy. And a 29% rate of grade 3-4 side effects during the neoadjuvant phase, not so different than what has been seen in prior studies. The conclusions are that clearly neoadjuvant therapy is here to stay. For that modest proportion, maybe 15% of patients with clinically detectable and/or palpable stage 3 melanoma, 2 cycles of ipi-nivo, to me, is the way to go. And I think this is an excellent advance, which will decrease the risk of patients who get a 90% pathologic response or more of ever occurring, and probably will eliminate the need for further surgery. But again, with only 9.9 months of follow-up, time will tell. The second very interesting abstract was presented as one of the orals, and this was by Dr. Paolo Ascerto from Napoli, who talked about the results of the Relativity 48 study. This was a phase 2 study of 46 patients who received, now for the first time, triplet immunotherapy with ipilimumab-nivolumab and relatlimab. They received nivolumab, relatlimab at the usual fixed dose of 480/160 every 4 weeks, and every 8 weeks they got 1 milligram per kilogram of ipi out of concerns about if that interval had been shorter or the dose higher of seeing more toxicity. Primary endpoints were safety, response, duration of response, and progression-free survival was a key secondary endpoint. And again, we now have 49 months of median follow-up, and it was a very healthy and respectable group of patients with a significant rate of elevated LDH of about 37%. 52% had M1c disease. So this was a really good representative group of stage 4 melanoma patients that were unresectable and had metastatic disease. And the investigator called response rate a very nice 59%. Interestingly, if one looks at PFS, at 3 years, 52%, at 4 years, 52%. So amazingly, there is a plateau, and it looks like the median will not be reached at 4 years, and that is a phenomenal median survival compared to something like 11 months for CheckMate 067, or in the flip-dose ipi-nivo arm of CheckMate 511 of 10.2 months. So again, very nice data, suggesting clear clinical benefit, in my opinion, for that triplet therapy with a 39% rate of grade 3-4 immune-related adverse events, still a very significant rate, but again, looking at survival, 72% at 3 years, 72% at 4 years. That beats 59% seen for CheckMate 511 with the flip dose of ipi-nivo. So again, very nice data. And this, of course, was a moderate-sized phase 2 study. It needs to be subjected to further verification, and those studies are now ongoing. Finally, we heard the long-term follow-up of COMBI-AD, which was the randomized trial in the adjuvant mode in stage 3 ABC resected patients by AJCC7 of dabrafenib-trametinib oral drugs for 1 year versus placebo. And we've seen the 3, 4, and 5 year follow-up. Now we have 100 months of follow-up minimum. And this was essentially the final report on recurrence-free survival, which was the primary endpoint. And it's 50% at 100 months with a plateau where it really looks like the recurrence-free survival levels out. And if you look at distant metastasis-free survival, 64% at 100 months. At 5 years, it was 65%. So I think that's a real plateau. And if you look at overall survival, there is a difference. At 100 months, 71 versus 65%. And again, the p-value just misses at 0.063, but the hazard ratio is 0.8, and the curves come apart early and stay apart all the way through that 100 months of follow-up. And interestingly and almost bizarrely, if you look at the forest plot of different factors, for those who are BRAF V600E mutated, again, clear benefit in terms of recurrence-free survival and overall survival. But if you look at the V600K mutations, which only represent somewhat less than 10% of the total BRAF mutated population, which of course is 100% of the patients in this trial, it goes the other way. The hazard ratio is 1.95, suggesting that the placebo group actually did better than the group that got dabrafenib-trametinib, which is really hard to understand, given that for recurrence-free survival, there's benefit both for V600E and K. If you look at melanoma-specific survival, similar data to the overall group, again, 76% at 100 months versus 70%, which I think clearly establishes that dabrafenib-trametinib is an impressive standard of care adjuvant therapy in patients with stage 3 ABC disease by AJC7 who are candidates for adjuvant therapy and are BRAF mutated, whether E or K. Again, please feel free to call in with questions or comments. This is Dr. Jeffrey Weber reporting to you on this most recent ASCO meetings melanoma abstracts. Thank you for your attention.